Assalamu alaikum everyone. Good morning. On behalf of GDP, today we are here to listen to a webinar on a topic canine guided occlusion versus group function occlusion. So I, Dr. Nadira, host and moderator for today. I'm a prosthodontist and implantologist working as a senior lecturer at Bangalore Institute of Dental Sciences. Welcome all of you for this webinar session. So before we go ahead with the session by our speaker, so we should know a basic things about occlusion. Occlusion is nothing but a relationship between our maxillary and mandibular teeth when we say in layman terms. But according to Glossary of Prosthodontics, occlusion is defined as a static relationship between the incisal or the occlusal surfaces of maxillary and mandibular teeth and even in the dentures. So why is it important to study occlusion in our dental practices? The basic principle here is like whether we are a general practitioner or a specialist practicing without a comprehensive understanding of our occlusal principles would be costing us a penalty in diagnosing a case which would lead to unpredictable treatment results and loss of production time and giving an improper treatment to the patients. Therefore, the first goal of studying occlusion system is to achieve the concept of complete dentistry. The complete dentistry means to give a patient freedom from disease in all the masticatory system structures, where we can maintain a healthy periodontium, stable TMJs, stable occlusion, maintainable healthy teeth, comfortable functions, and optimum aesthetics. These refers to a complete dentistry, what we are going to practice. Hence, why occlusion plays an important role in a dental practice is occlusion is an important part of a masticatory system, where the teeth are placed in the mouth determines the ease of activities like smiling, speaking, and eating. Hence, a proper chewing of food ensures that the chances of developing plaque are lessened. Hence, a proper able to speak properly is another major activity which usually depends on our dental occlusion. In case, if in young children, if the occlusion is improper and if it is not treated properly, it might affect the teeth that are going to be developed. Hence, it can affect the look of the face and also can cause dental diseases and speech problem in the younger kids. Also, it might lead to a temporomandibular joint diseases, and they also lead to temporomandibular joint diseases. Hence, the causes of malocclusion can be from a hereditary way. To some, it can also be from the trauma or habits which are developed in childhood. In some cases, the tooth malocclusion can also occur due to extraction and not replacing it in a same time. Hence, occlusion plays an important concept in dentistry. Hence, the success of many dental treatments rely heavily on a stable and a harmonious occlusion. Hence, before we start going in detail about occlusion, all dentists should understand that even when they are making a simple occlusal composite or amalgam restoration, they should first diagnose and treat occlusal disharmonies in order to avoid creating iatrogenic occlusal or temporomandibular joint disorders. Every dentist needs to know the fundamentals of occlusion and they should be able to diagnose the patient's functional status. Dentists should always make appropriate decisions regarding the type and extent of treatment, and they should plan individualized occlusal schemes according to the unique demands of each patient and the treatment they are giving to them. As the treatment approaches and clinical procedures are constantly improving and becoming more accurate and less invasive, as there is development of many restorative materials and improved and new product developments and new techniques which have been involved. However, it cannot be said that the same degree of evolution has occurred in understanding the occlusion, which is one of the greatest pillars of the long treatment success. Today, we have among us our speaker, Dr. Danish, who is a prosthodontist and implantologist, who did his undergraduation from Rajarajeshwari Dental College and Hospital, Bangalore, and post-graduation from VS Dental College, Bangalore. He is going to take us on a topic, canine guided versus group function occlusion. On behalf of GDP, I welcome Dr. Danish, who is the speaker for today's topic, and I ask him to take over the session.
Hello, am I audible?
Danish, a bit louder.
Hello.
Yeah, you're audible now.
Yeah. Hi. Thank you for that brief introduction about the topic as well as me. So the topic for today basically is I am Dr. Danish. I am a prosthodontist and implantologist, like how Dr. Nadira has already told. So, ma'am actually wanted me to talk about canine guided versus group function. So, the topic today, I would be dealing with it in terms of like the basic terminologies that we need to understand on what it is, as well as on how we can deal with it in cases. And there are some case scenarios that I've illustrated in the PPT. So as we go through, you'll know about the basics as well as how and when can you apply this particular occlusion that is there in our clinical cases, as well as finally the most important that is during full mouth rehab cases. So I'll start. Is the screen seen?
Yes, Dr. Danish, the screen is visible.
Okay. So the first and more foremost thing that we already know is occlusion is actually the most important thing that we see. The patient who walks into your dental clinic should comes not just for a missing tooth or for a restoration, but eventually for a proper bite that he needs to get back to. That is most important right now in current dentistry. We think about aesthetics and other functions, but eventually the patient would not be happy as long as the bite is not good. So the first and more foremost importance that we have to see is that the patient has a good stable bite. So as we go into occlusion, there are different types of occlusion that I'll be dealing with. That is balanced occlusion, canine guided occlusion, or group function. So what we should know is ideally when we have been taught about things like the person should have a proper class 1 occlusion where the buccal cusp is coinciding with the maxillary buccal cusp is coinciding with the buccal groove of the lower, and there should be a proper overjet and overbite with no attrition and all of this. But when we see in our clinical scenarios, most of our patients who walk into our clinics do not have these kind of occlusion. That is, some of them usually have either caries or they have attrition or they have a missing tooth and all of these, which eventually leads to malocclusion and disturbances in the oral cavity. So we need to make sure that all of this is addressed first, and then we take into consideration of any other changes to the occlusion. So before I go into the cases, first thing we need to know is there is something called a centric occlusion and maximum intercuspation that we already know. Centric occlusion is when the jaw is in centric relation, that is the mandible is at its physiologic rest position, the muscles that are acting on it are at rest position, there is no strain that is present. So at that condition, that is the best occlusion that one can have. And then comes maximum intercuspation. That is when a person completely bites where there is a proper cusp to fossa contact of the posterior teeth. So the best occlusion is when the centric occlusion as well as the maximum intercuspation both coincides. So that should be our ideal goal. So coming on to that, the most important thing among our oral cavity is your musculature, which we give a good amount of negligence that is there. That is, whenever you have a good, proper occlusion and everything, in those cases, as you can see here, the strain that is present on the muscles is very, very minimal, which is ideal. Like in cases of opening, there is the suprahyoid muscles that are activated, while in cases of closing, there is masseter, the temporalis, and the pterygoids that are activated. So if in cases when you have given a ill-fitting restoration, as you can see here, there's a high crown that is present. In those conditions, all of these muscles, they get triggered. So the first response of the patient would be with a headache. Like normally we have seen in most of the cases where we have done a restoration or we have given a crown and things like that, patient would have just left the clinic happily, but you can see that eventually they call back and tell that they had headache the previous night and things like that. That is especially because of the high point that was present with case of our restoration. So in those cases, the muscles are the one which are activated first. So like how Dawson has already told, like whenever there is a war between muzzle or the teeth, the muscles will always win. So in those cases, you have to make sure that there is no high point and all of this when the patient is leaving the clinic. Only then the muscles will be in a good relaxed state. So there are few things for us to attain this proper stability is like there are the like when you call an occlusion to be properly stable and successful is when you have a comfortable TMJs that the patient has no pain in the TMJs as well as there is anterior teeth that you see here. The canine to canine are in good relation to each other. That is, you do not see any increased overjet or overbite. And whenever the patient is doing lateral or eccentric movements such as protrusion and all, there is a stability that is present. That is, posterior gets disoccluded. I'll be explaining about this in the further slides. And there are non-interfering posterior cusp, as it means like when you're doing lateral movements, as in biting on the lateral side, there is no interference that is present. So this is what we have to know. As you can see here, the dots that are present here is nothing but those dots are the contacts when you see during static occlusion. That is, occlusion is of two forms. We already know about it. There is something called a static occlusion is when the person is just biting or clenching. At that point, that is the static occlusion, while the lines that you see here is nothing but the dynamic, that is during the movement, as in cases of chewing or mastication. So we have to see when does it get stabilized. This in cases whenever you have a anterior when the person brings it into the protrusion, when you have canine guided or a mutual protected occlusion, there you can see that there's a clear disocclusion of the posterior teeth. In those cases, these muscles that are present are at a good relaxed state that is there. So this is what we need to achieve. So how does this affect? Why should we know about the posterior determinants? Posterior determinant is nothing but a TMJ, how it is sitting into the glenoid fossa, how that angle of the glenoid fossa is present. So this affects our cusps that is present on our posterior teeth. So during our restorations, when we are giving, especially in cases of full mouth rehabs or in cases of complete dentures, that is where balancing comes into picture, is where you have to make sure that the condyle guidance is recorded and your cusps are selected according to that guidance value. So that is what, if at all the condyle guidance that is there present here is more steep as you see here, then the cuspal height will increase and even that will be steeper. Or in cases where it is shallow, the cuspal height can be kept a little less and it will be shallow just to be in parallel with the condyle guidance. Coming on to the anterior determinant, like I've told, there is anterior determinant. That is how your upper canine to canine, that is the anterior teeth, are in relation with the lower anterior teeth. That is, if at all there is an increased overbite, there will be increased amount of steeper angle. That is, the anterior determinant will have a steeper angle. Or if at all where you have a proper to 2 mm, that is what ideally is expected, about 2 mm of overjet and overbite. So in those cases, you have a good amount of anterior guidance that is present. Or in cases where it is less, the guidance, what you call the degree becomes shallow, as you see here. So how does this affect? Is it's completely under the control of, like, not like completely, but it is under the control of the clinician. That is, you can determine how the anterior guidance plays a picture is by you can check the aesthetics of the patient, how you are arrange the anterior, that is canine to canine, based on the patient's aesthetics, based on the patient's speech, how he talks, and based on his smile line. If he's happy, that is where the canine guide, so that is where the anterior guidance comes into the picture. So you have to make sure that it is not having too much amount of deep bite, because that will again affect your posteriority. So this was a theory that was given by Dawson, where he suggested that the teeth among this anterior determinant and the posterior determinant, he suggested that which has more impact on your occlusion or the pain that the patient has is on the basis of this nutcracker theory, as explained by Dawson. That is, anything that is closer to the screw will have more amount of effect on the TMJ. So like for example, here if you see, imagine this as the TMJ and this as the posterior teeth, this as the anterior teeth. So if you have to crack this nut, if a person has to bite it, the amount of force that is needed if he bites in the front is more as compared to the posteriors. That is, anything that is closer to the nut will definitely have more impact on it. So as you see here in the oral cavity, this is the TMJ, that is the condylar guidance that is present, and the anterior teeth that is present is away from the TMJ. So this will have a lesser amount of forces that are acting on it. So these teeth can produce more amount of disocclusion that is there posteriorly. So I've already explained this. By increasing the anterior guidance that is there, you can always compensate for the condylar guidance that is present. So coming on to the different types of occlusion, now that we know the basics of how this occlusion works, so there are different concepts that have already been explained in literature, such as there is bilateral balanced occlusion, there is unilateral balance, and the mutually protected. So among this, the bilateral balanced occlusion was initially taken up by Stewart and Stullard, and it was propagated by McCullum as well, to tell that we could have tried in fixed partial dentures, but then as they did and tried it in the what do you call the normal FPDs like our natural teeth, so it led to a lot of failures because our natural teeth act as an individual unit. Like yes, every teeth has its own individual movement that is associated with the periodontal ligament that is there. And every teeth has its own amount of bone support and different forms of the root. So it does not act like a single unit. While you see in a complete dentures, that is where it acts like a single unit. So you can use a bilateral balanced occlusion only in cases of a complete denture. And when it was used in cases of natural teeth, it led to a lot of failures. So this is the case of bilateral balanced occlusion, what it looks like. I just wanted you to know. So it's like when a patient is biting in centric, there is a proper occlusion as you see on both sides. And as the patient brings it in protrusion that we are seeing here, so when it brings in protrusion, there is a bilateral simultaneous contact on both right as well as on the left side, as well as in the protrusion movement. So this is what it means about the bilateral balanced occlusion. Now we are asking the patient to bite in-centric again. And then we are asking to take it to the lateral movements. Again, you can see there is a buccal contact that is also present, as well as the palatal cusp of the maxilla and the lingual inclines of the mandible are contacting on the working side. So there is always contact on the working as well as the non-working side in cases of balanced occlusion. So this was only and is supposed to be only followed for complete dentures and not for the natural teeth. So moving on to how do you attain this bilateral balanced occlusion? As we know in complete dentures, the steps I'm not going to talk about, that is the basic steps of primary impression, secondary impression after border molding and all of that. So the major difference comes after the jaw relation. That is obviously for all the cases we are supposed to do the faceboard transfer that is done. And after the faceboard transfer is mounted, you take the, you attach, there is something called as tracers that are attached to obtain this. So you attach this Gothic arch tracers to the occlusal rims, then ask the patient to give you the arch tracing. This is where you verify if your jaw relation was correct, how you have mounted, and how you have taken the bite. So what do you ask? You ask the patient to bite in the centric. That is where you get the first dot. You ask the patient to then bring it protrusive. You get a straight line that is present. And then you again ask the patient to bite in the centric. When you see that the patient is repeating this particular point of biting in centric, that means your centric is correct. And then you ask the patient to take these lateral movements. So you should be able to clearly see this arrow point tracing that is there. As you can see here, there's a clear-cut arrow that is there, which depicts the arrow point tracing that has to be seen during balancing cases. So after this arrow point tracing is done, you take the record of it, then you do the anterior teeth arrangement that is done. And this anterior teeth arrangement has to be tried in the patient's mouth. You ask the patient to bring in protrusion, check that the occlusal rims are still in contact in that. And then you go ahead with the posterior arrangement. And once the posterior arrangement is done, you reduce the any occlusal interferences in the on the articulator itself after you have adjusted the condylar values and all of these. I'm not telling it in detail because the topic will get deviated from the canine guided occlusion. So this was just to give a brief idea about the balanced occlusion. So again, same thing, you need to just verify it in during trying procedure. If at all you have proper contacts during centric, then you have good contacts during protrusive movements. That is, you ask the patient to bring in protrusive, check if you have buccal contacts as well as the lingual contacts, and both on the balancing as well as the working side. So this is on the lateral. As the person is taking it to the lateral, you should also take into consideration that the patient cannot move it to lateral as well. So that was all about balanced occlusion, which is no longer followed for our natural dentition. So coming onto the occlusion that is ideally told to be followed in a natural dentition is either your groove function or canine guided. Now this again totally depends on what the patient already has in his mouth. So we cannot change whatever is present in the oral cavity, rather just do the basic restorations according to whatever is present in the oral cavity or already existent in the mouth. So coming on to what is unilateral balance or group function, as you can see the picture here, that is whenever the patient, this is all about how the eccentric movements is taken into picture. So that is, this is lateral occlusion. That is when the patient bites in centric, it is in centric, and as he moves to the laterally, you can see that there is contact on the working side on whichever side the patient moves, and there is complete disocclusion on the non-working side that is present here. So this ideally is followed in most of our cases. That is, as the patient ages, this is the groove function that it leads to. In the groove function, the most common feature that you see is either the canine is untreated. That is why you have a lot of contact of the posterior teeth. So groove function basically means contact of one or more than two to three teeth. Ideally, they prefer the contact of canine as well as the premolars and the mesial cusp of the molars to have a good contact. So coming on to something called as mutually protected occlusion. In mutually protected occlusion, this is in most of the cases that we see in natural dentition, where the posteriors, when the person is biting in centric occlusion, you have good contacts in centric and there is no contact in the anterior part. So that is the posteriors are protecting the anterior teeth, and the anterior when it is brought in protrusion, as in cases of biting or in cases of biting or tearing forces in anteriorly, there is complete disocclusion of the posterior. That is, in protrusion, the anterior protects the posterior, while in centric relation, the posterior protects the anterior. So how does this is different from the balanced occlusion? Is that in cases of group function or other things, in cases of group function, this is what you see. There is something called as horizontal chewing. That is the forces that are acting are directly on the horizontal surfaces. That is, it is on a larger occlusal surface as compared to the canine guided occlusion. That is the vertical chewing, where the canine pushes the teeth to contact, that is the opposing cusp to contact the fossa, where it is directed against the central or the vertical axis of the tooth, which is more advantageous as compared to the horizontal chewing. So how do we see that when do you have to restore these kind of condition? Is like, this was one of our cases where the patient had come to us reported with a missing tooth of the upper canine, upper premolar, first premolar as well as the first molar. So this was a prior abutment cases. In this case, what happens? We have to give a long span bridges. So in those cases, you don't have to change the occlusion. Now what happens is, because we are involving the canine here, we need to know about the occlusion here. So in these cases, first thing we have to see is, first we have to check whatever the occlusion that is existing in the patient's mouth. This patient had groove function occlusion that was already existent. So we have to make sure that we restore it back in groove function only and do not try to change it to canine guided, because it's her oral cavity would have already been stabilized to whatever occlusion that is present. So do not try to change. We do not try to change that and try to replicate whatever is already existing there. So in this case, we tried this is the metal trine, and in cases of prior abutment, as we already know, it's always best to give a non-rigid connector of precision attach, a non-rigid connector of a male and a female attachment that is given to reduce the stress on the prior abutment. So this is how it was followed, and it was again restored back in groove function only. So moving on to canine guided. So canine guided is also part of the mutually protected occlusion. So what basic difference that we have in canine guided is, here the entire load is taken up by the canine during the lateral movements. That is, whenever the patient, whenever we do the lateral movement, the canine comes into contact and it causes complete disocclusion of all the posterior teeth that we see. So this, in ideal cases, this is what the occlusion that is preferred to be given for the natural dentition, because the canines are the cornerstone and they can take up this load, and it protects all the other teeth in any other excursive or lateral movements. So as you have seen here, this is where in centric occlusion, there's a normal occlusion that is present, but when the person moves it to the lateral side, you can clearly see that there's a complete disocclusion of the posterior teeth. that is present. So for the canine guided occlusion to exist, the main important thing that we need to know is it is the canines which have to be sharp and it should not be treated. That is the major importance that is seen. So this was a study that was conducted where they have tried to find out, like it was a diagnostic a study that was done to find out what is the most amount of prevalent occlusion that is seen in cases of an individual. It was a randomized study that was done where 842 subjects were taken with natural dentition, and there was a complete no restorations or no prosthetic replacement that was given in these patients, and these were the ideal kind of cases who did not have any occlusal changes that were done to their oral cavity. So in those cases, when they actually found out which type of occlusion existed, they found out that in cases of adult individuals, the majority had the bilateral canine protected occlusion because the canines were not treated and the canines were completely intact. So there was a canine guided occlusion that was most common in young patients, but as the age happened, there was wear and tear that was seen in the older patients. So older patients often presented with group function occlusion. So this was one of our other cases where we had to do the anterior aesthetic correction where the canine was again involved. So here this patient presented with a anterior deep bite and her upper anteriors were protruding more as well as it was longer for her, and her smile was not good. There was mobility which was present with respect to 2-1, and there was a midline diastema that was associated. So in this case, we could see that the occlusion that was present was canine guided. As you can see, the canines are quite sharp and it is not treated. So the patient had canine guided occlusion. So we should make sure that we replicate this canine guided back and not change it. So the first thing that was done was pictures were taken. We had to do smile designing for this case digitally and try to see how we could correct it if at all the case could go ahead without any extraction or if it needed RCTs. So following which following the smile design, when we did according to the Golden's proportion and which fitted this patient's mouth, we had to take the pictures of the face and correlate the canine to canine proportion to her face proportion, and found out that it was best to extract 2-1 as it also had mobility, and then go ahead with RCTs of the centrals and the laterals, and then only go ahead with the treatment. So we did that, and this was the final restoration that was given. The zirconia was given, and you can see that the canine guided occlusion was again replicated in the case. So you can clearly see that the canines came in contact, and on the second quadrant, as we see, the canines was not involved because the canine was good and we did not need it for support. So we did not need any additional support. So canine was left intact. So it was just the 2-3 that was involved. So this is how the patient had come, and she was very happy with her occlusion. We had to make sure that her anterior size of the teeth was also reduced according to her face. And then before you send the patient, the best thing is to check with the speech and everything if she was okay with it and all of that. So this is how the patient's speech was when she spoke. There was no disturbance according to her. So there was another study that was conducted which compared the stress transfer that was seen by the mandibular movement, like in cases with the patient who has anterior guidance, like I've already told, where there is a canine guided occlusion, or your other again in the eccentric movements where there was group function. So this was among two cases where they did an electromyography test where they tried to check the muscle tension that was present as well as in the TMJ. They found out that a more amount of stresses were seen in group function as compared to the canine guided. It does not mean the group function is bad. It was just a study that was tried to check with the comparison between the canine guided as well as the group function, which has more amount of stress. So the canine guided was found out to have the least amount of stress. Now we need to understand why canine, because as we know, the more posteriors have got are multi-rooted, the more amount of roots have got more bone support. So why only canine, which is single-rooted? So first thing we need to know is the canine is the tooth which has the longest root in the oral cavity. That is why it's also called as a cornerstone, because it has the maximum amount of bone support, the more amount of mechanoreceptors. That is why the proprioception is best for canine, as well as it is at a position where it is ideal for it to be present. That is, it is so much away from the TMJ, where the forces are acting are less as compared to the posterior teeth, and it is also closer to the TMJ as compared to the anteriors, where it can have more amount of impact on the teeth as well as the TMJ. So, but you should not be using canine if at all there is some amount of like more amount of the periodontal breakdown that is seen, that is the bone loss that is present here. In these cases, you should not use canine, or in cases where there is the canine is having some amount of mobility, or where there is a wear and tear of the canine, there is more amount of attrition. You should not try to give canine guidance in those cases. And especially the most important factor is the periodontal breakdown that can be associated. So there was a relationship of the canine protected occlusion to the periodontal index that was conducted by Gary Robert, and he found out that wherever the canine guided occlusion was given, the periodontal scores of the remaining teeth of the oral cavity was very less as compared to the group function, because the stresses were not given to the other teeth in cases of lateral movements. So when do you actually check these occlusions and do the amount of changes? You need to first ideally check how the patient is in the oral cavity. That is, you have to make sure that the patient has got a good amount of what do you call the patient adaptability is there. Like in this case, where you see first thing is some amount of patients when they come to us in the clinics, we see that there is some amount of attrition, there is some amount of restoration. We do not have to directly jump into changing that occlusion. There are some patients who must have had a deep bite also. They might have had some amount of restoration also, but then their threshold of pain will be very high. In those cases, diagnosing those cases becomes difficult for us, because the patient will not have pain in those cases. You would have gotten used to it, even if there is some bruxism, even if there is some amount of wear and tear or attrition that is present, but the patient has no symptoms. So those patients become more difficult for us to diagnose. But in some cases, the threshold level is very less. That is, the pain threshold is less. So any minute changes will cause a discomfort to the patient. So these patients will be very easy to be diagnosed. So we have to see what amount of wear and tear has happened. So first thing we have to see is this threshold is taken care of. And after that, only you do some amount of occlusal changes. So how do you do the restoration changes? So there are few cases that we see, like for example, in cases of a class 2, where there is some amount of anterior overjet is increased. In those cases, how do you normally restore it? The ideal cases is to check with the orthodontist, to check with ortho corrections and all. If the patient is not willing for an ortho corrections, you can still try to check it, do some amount of changes with the prosthetic change, such as in cases of upper maxillary, you can try to build the canine maxillary, you can try to build up the lingual inclines of the upper teeth. That is, you extra contour the upper inclines of the upper teeth. That is, the lingual inclines, you extra contour it, as well as you bring the lower anteriors a little forward, so that there is good amount of contact, especially in case of centric, there is stable contact. And as the patient brings it into the protrusive contacts, it causes the canine guided occlusion or group function, whichever is best for the patient. So again, as you move on to the most commonly cases in class 2 that you see is there is a complete passing of the lower canine between the embrasure of the canine, upper canine, and the premolar. So in those cases, what you can do is you can just build it or over contour the distal aspect of the canine. This is also called as the canine rise method. So where you just build up the extra canine structure that is present, which causes an obstruction with the lower canines, causing the canine guided occlusion. This is one simple method of restoring the normal cases of class 2, if the patient does not want an orthodontic correction. But in cases of class 3 plays difficult cases where there's a mandible prognathism that is present. So ideally, this has to be corrected with a orthodontic corrections itself. But there are some cases where it can be corrected by restorative method. Like this is one case which had come to us in the clinic where the patient had a class 3 occlusion where the mandibular prognathism was present. As you can see here, the mandibular anterior teeth were forwardly placed. As a result, the patient had mobility of the lower anteriors, but he had good occlusion of the posterior. The patient had proper groove function occlusion that was seen. So in these cases, and the patient was not willing for an ortho treatment, he was also old enough for an ortho treatment. So, and the anteriors were mobile. So then we went ahead with the posteriors. That is the first thing that you can do is you will have to evaluate how the cases, take the Facebook transfer, mount it, and then check how the patient's occlusion is and what you can do ahead with it. So you'll have to do a mock-up of the patient if at all it needs some amount of RCTs or if it needs any extractions and all of that. So once this was done, the best method is to fabricate temporaries. Once the temporaries are fabricated, as in this case, we tried the temporaries in the patient's mouth, checked for the aesthetics, checked for his smile, check for his also the speech and everything if it was proper. Once the patient was happy with it and we were happy with it, so we went ahead with the posterior restoration. In this case, the posteriors were digitally designed to make sure that the anteriors were present with good overjet and overbite ideally, and they did not have cause any discomfort to the patient. So once it was done, this was the final restoration that was given, and the occlusion was again verified in the patient's mouth. As you see here in the lateral excursion movements, there is a proper groove function that is continued and it is not changed in the patient's mouth, and it is still the same as the patient had come to the dental clinic with the anterior class 3 situation correct. This was another study that was again conducted, again a diagnostic study that was done to check which amount of occlusion that was naturally present and what would be the more ideal situation to be restored for the patient. So they found out that as the younger patients were present, there was bilateral canine guided occlusion that was present. But as the age happened with wear and tear, it was again groove function that was seen. So sorry, the occlusion was then restored back to the same thing, and the study concluded that it was best to restore the younger individuals with canine guided and the older individuals with group function. So when do you have to do these corrections? That is, like I have told before, it is the full mouth rehabs that has to be taken into picture. So when do you ideally do it? These are the signs and symptoms that you see in the patient's mouth, which tell us that yeah, it's best to do some amount of correction in the patient's mouth. That is, whenever there is large amount of occlusal wear facets that are present, or there is trauma from occlusion, that is again has to be verified by doing the Fremitus test, and also whenever there is pathologic migration which is leading to malocclusion in the patient's mouth, or there is tooth mobility that is also being caused by the improper occlusion, patients having TMJ problems and pain, and when there is muscle tenderness and the soreness that is present. So the best method that you have to do is first diagnostic step. That is, you do this Dawson's technique where the patient is in supine position. You do this Dawson's method where you're loading the posterior jaw and checking for the centric occlusion and checking if at all the patient has any centric problems. If there is no centric problems, then you have to restore it back to this bite. The bite is then taken, the bite is then recorded, you mount it, then you check for any interferences that are present. So what is an ideal occlusion? When do you call it like an ideal occlusion? That is, this was given by Dawson, Occasion, as well as our Pankey and Schuller. So they told that the best would be when the patient has got a stable contacts on the all the teeth. In cases of centric relation, they have good stable contacts, and it would be best if the centric relation also coincides with the maximum intercuspation. And the best ideal occlusion will be when the anterior teeth in protrusion brings the disocclusion of the posterior teeth, or based on the patient's oral cavity, if it is a group function, which is best in case of old patients, that has to be restored. And you have to make sure, like ideally, if the forces are directed along the long axis, like I've told, that is called as the vertical loading, which is most commonly seen in case of canine guided occlusion. So there was a study that was done on the occlusal plane, how occlusal plane acts. So when are you supposed to do these changes? That is, if the patient has walked into your clinic and you see that there is some amount of missing teeth, there is some amount of missing teeth that is present, and because of the missing teeth, there is adjacent tooth migration, or there is supraeruption of the opposing teeth, and all of those categories that has happened. So in those cases, the first step for us would be to diagnose it and to correct this plane of occlusion, because if this plane of occlusion is not corrected and we have gone ahead with our treatment of restoring the missing areas, of the opposing arch or things. So in lateral excursion, when the patient does the lateral movements, that is in cases of side lateral, that is right lateral or left lateral, or in case of protrusion movement, there will be more amount of discomfort that is there. So the occlusal plane has to be taken into consideration first. So this was our case of full mouth rehab. So when you take into consideration of all of these cases is, in cases of full mouth rehabs, there are various concepts such as Panky Man concept, there is nathological concept, there is Hobo's concept that can be followed, whichever is best for the patient. So the diagnosis is most important. This was one of our cases where the patient had reported where she had complete alteration of the posterior teeth. The vertical dimension was decreased. The VD was completely decreased. The patient had reverse smile that you can see. The curve of the smile is completely lost. So this was the intraoral condition. The patient has complete deep bite because of the loss of VD that is clearly seen, and because of also that the patient had erosions that you can see. The label surfaces were completely eroded because of the contacts of the teeth that was seen. So in this case, the first method that has to be done is you do the Facebook transfer and then do the occlusal plane analysis like we do. It's called as Broderick's plane of analysis. On that basis, you get to know whether you will have to reduce the teeth further or you'll have to increase the bite and how much amount of bite has to be increased. And all of this has to be taken into consideration. Once we did the bite increase, the first step that you can do is the mock-up. That is on the basis of whatever technique that you're following. In our this present case, we followed the Hobo's method of twin stage. That is, you do the posterior mock-up based on one condyle values and the anterior mock-up on the other condyle values. So this was the mock-up that was done, following which the posteriors were first restored to the patient. After you have done the posterior restoration, where you can clearly see that the deep bite is taken into consideration. In this particular patient, we also had to do crown lengthening so that we could get enough surface for the tooth preparation and restoring of the teeth. So once this was done, we allowed the patient to get used to this increased vertical dimension, and also an occlusal splint was given because the patient was a known bruxer. So to prevent the nocturnal or the sleep bruxing, we had to give a occlusal splint that was given. So this was following the posterior just restoration, that is temporaries. The patient was allowed for about 2 to 4 weeks, and then the patient returned, and we had to give the anterior restoration. This was again based on the mock-up that we had done on the and now on the basis of occlusal plane analysis. So once the anterior temporaries were placed in the patient mouth, patient's aesthetics as well as patient's speech was verified, patient's smile was verified, and then we also saw that the patient had the mutually protected occlusion. That is in cases of canine guided also in this particular case. So when the patient brought the teeth into protrusion, you can clearly see there was a clear disocclusion of the posterior teeth. These are the temporaries. And then the final restorations were given with PFMs, that is porcelain fused to metal. So as you can see, in cases of centric occlusion, there is a proper occlusal contacts of the posterior teeth, but when the patient brought it into the protrusion movement, there was a clear disocclusion of the posterior teeth, especially in the protrusion movement as well as in lateral excursions where the canines came into contact, there is a clear-cut disocclusion of the posterior teeth. This was the post aesthetics that was restored for the patient. There was another case where the patient came reported to us. This was a cases of implant, full mouth implant that was done. That is upper arch was restored with full mouth implants, and the lower arch had a fixed crowns that was present. This was a patient who had came back to us with a fractured processes of the upper, and there was a repeated fracture that was seen, and then the patient was not mentally completely stable also. So it was quite difficult to ask the patient to bite into the proper centric, and the patient had to be trained for this. In this case, where we took out the restoration, you can clearly see that there was a lot amount of food lodgement that was there, especially because the inner surface of the restoration did not have a convex surface or a smooth surface which could deflect the food particles and not cause its accumulation. So in this case, you can see that the metal framework was a little bit lingual. That is why they had to build up the whole restorative contact with PMMA to compensate for that, which again led to the contact of the patient here, and there was a decreased vertical dimension that was seen in this case. again. So we had to take the impression, that is open tray impression was taken, the jig trial was verified in the patient's mouth, then the framework was again verified, and then the jaw relation was done. The jaw relation was verified according to the speech and aesthetics according to the patient, and the bite was done. So once this was done, this is the final restoration that was given to the patient. The final restoration was fabricated with CAD-CAM dentures. That is, this is a CAD-CAM milled Bredent dentures for full mouth implants. So this we made sure that the as you can see in the previous slide, the framework is not as wide enough and it is not lingually placed. We made sure that it was on the ridge, and any contact with the lower teeth was avoided. So that you see here, this is the major difference that you see in the previous processes to the current processes. The bite that was there, we try to get it directly on the long axis of the tooth and onto the ridge, and try to keep the framework as forward and away from the lower teeth contact that you see here. So the lower teeth could not contact on the framework or onto the acrylic, which would cause the fracture of the teeth. So this was the occlusion that was restored to the patient. The patient did not return back for the lower anterior corrections. So this was how the patient was before with the processes, and this is how she returned. So coming on to which occlusion would be the ideal cases to be followed, is that we know according to the various studies that was done, this was again one of the studies which was done if canine guided was the best or the group function was the best. So the ideally according to Dawson's and other, it was told that whichever the patient is stable, like as the patient is born, as a person, a human being is born, the first thing to be developed is the oral cavity. In the oral cavity are the muscles and the ridges that is there. It's not the teeth that the patient is erupted with. So the muscles come into picture, and the muscle and the TMJ get used to the patient and they get stabilized. And after that, the teeth starts to erupt in relation to this muscle relation that is present in the oral cavity. That is, the teeth get erupted according to the muscle and not the muscle that gets developed according to the teeth. So we have to make sure that the teeth are not changed much, because that affects the musculature of the patient. So as Dawson has already told, if the muscle and the teeth will have a fight, it is always the muscle that will win. So if you are not restoring it in a proper occlusion, there will be attrition of the teeth and eventually failure of the treatment. So according to this various studies, they told that you can follow the canine guided all the group function depending on what was existent in the patient's mouth. And ideally, they were more inclined that the group function was followed when you're doing it for the older patients, and when you're doing it for the younger, it was the canine guided occlusion. So this was the conclusion, that you can, before restoring of any teeth that we see or restoring of the oral cavity that we see, you do not directly jump into the changing of the overall occlusion that is present. That is, if the patient has group function, do not change it to canine, or if the patient has canine, do not directly change it to group. So its best would be to just restore it back to whatever is existing in the patient's mouth, and try to make sure that the muscles are stabilized first, and only then will the oral cavity be stable. So you have to see that few points that I tell you for the takeaway is that in centric occlusion, there has to be a proper bite, stable contacts of the posterior and the anterior, and whenever the patient brings to the protrusive movement, there is complete disocclusion of the posterior, and whenever you have a lateral movement on the working side, there should be no contact on the balancing side. All of these will eventually help us to have a good occlusion and a long-term success rate. Thank you.
Thank you, Dr. Danish, for the wonderful presentation. I would like to ask if the participants have any questions related to this to Dr. Danish.
Dr. Danish, if you can stop sharing your slides. Well, please take over. Unmute yourself and take over. So we have a senior prosthodontist amongst us, Dr. Shahul. So probably he's Dr. Shahul. You can directly come on the audio.
Hello, can you hear me?
Yes, yes.
Yeah. Assalamu alaikum. Danish, sir, what a wonderful presentation. We really enjoyed.
Thank you so much.
Yeah. So, one small question, Dr. Sir. Um,
Ji.
what I've been seeing is when we do our full mouth rehabs, like natural teeth, even your PFZs, that is porcelain fused to zirconias and porcelain fused to metals, they tend to weather off or chip off and break off eventually. I'm
Yes,
talking
sir.
about not within the first year, maybe 3 or 4 years down the lane, or we see patients coming in who are already full mouth rehabilitated. And when we see their occlusion, now it is no more the same thing which was there before when it was established. There's
Yes.
chip offs ho gaye, kya? Probably for whatever reason, maybe. Now, how do we go to handle such patients when they deny getting their replacement of their worn out crowns? How do we, try to re-establish the canine guided or probably move them into group function? How do we really work on that?
So how do we really work on is like you're asking me if at all they are agreeing, that will again come into picture only if they are agreeing for a treatment in the first
Let's say
place.
if they are agreeing for that.
Okay. So in case if they're agreeing for the treatment, then I would suggest first would be like we would check the patient in a supine position, like how Dawson has told. We check for the centric occlusion if it is there. Take a bite. Then we would mount it on the Facebook, and then we would ideally check for the amount of occlusal plane analysis that has to be done. If at all it needs some amount of occlusal buildup, that corrections that has to be done or it has to be restored. And on that basis, we can try to first give a occlusal splint for the patient and see if at all it needs some amount of increase in the VD. If the VD is lost, like how you told, because of the wear and tear, so we'll try to give an occlusal splint for a while so that the patient can get used to that increased VD. If we see that the patient is getting used to that VD, then we try to do the mock-up according to that and give temporaries first rather than directly go for the prosthetic rehab for the finals. So give temporaries and again check if the patient is getting used to that temporaries. And once if the patient is used to the temporary, then we can again convert it to the final prosthesis.
So we are practically going to redo all the teeth. We are
Uh,
only looking at posteriors like
Yes, if
before.
the patient has only posterior problems and not the anterior, like if the anterior are aesthetically correct and it does not need much amount of correction, then I think only the posteriors would be good enough.
Would that hamper our anterior guidance?
Again, based on the anterior guidance, because we will see how much amount of the disocclusion that is present, or in case if the anterior guidance is too deep, or if it is too deep or steep, then in those cases we'll have to check with the posterior occlusion, or we can change the bit of anterior guidance so that we can have a proper occlusion posterior as well.
Oh,
If I've missed out something, sir, you can add on to it.
nothing. Because I really don't do much of full mouths, but whatever we do, uh, it's more implant supported thing. It's not the regular ones which I usually have had in my much of my
Ji,
thing. Very few of them we have done.
ji.
But I have had this genuine problem where patients come with full mouth rehabs already finished,
Yes,
and they have not been able to. Their occlusion is not settled, or it's been a couple of years of and they are worn out. Now they really
correct,
don't want to go back through the entire process to redo the stuff.
correct.
They don't want an overhauling done,
Mhm.
and they're like, "Can you adjust something and make sure we are able to probably do that?"
Yes, sir. So
So,
ideally,
do
like
we
that,
work
that's
on
what.
couple of teeth, or we need to redo the entire? Basically, do we only work on the posteriors, or we need to redo the anteriors and posteriors together? That was my.
I feel like if the patient is okay with her anteriors and all, we can go ahead with only the posterior part, sir. If the anterior guidance is still maintained well.
Okay.
Sir, the main problem for the wear would be like the patient habits, like bruxism, or if the patient has not discontinued the habit and if they have not counseled it properly. Because first they tell like if we are doing a full mouth rehab or something, so there has to be breaking of the habit first, so
Yes.
that a full mouth rehab treatment success would be for a long period of time.
I would love to do that if if our patients would be very cooperative enough to wait for the habit to break and then get their rehabilitation done. Most of us would be like, patient mil gaya, bas kafi hai, ab shuru karo.
But sir,
Rather
if
than
we explain the patient about the long-term success, I think a few patients, at least not everyone, a few understanding patients would like to think
yeah.
about it at least.
So what I do in my practice is whenever we do any type of changes in the occlusion for the patient. That means when we're doing when let's say we are doing a quadrant implant placement, I'm changing. We are going to rehabilitate entire one side of the quadrant, or we are doing a full mouth rehab with implant supported bridge and prosthesis. We tend to make sure that irrespective of whether the patient had any parafunctional habit or not, post procedure, we
Yes.
immediately, as a part of the package, we put in the patient with a soft splint in the night,
Yes, sir.
because we do not want patients to coming back with chip-offs or loosening of the crowns.
Correct. So
So
even in our this full mouth cases also we have, like, I forgot to tell that in this case also I had given occlusion splint. The soft splint is provided,
we
and the
need to be
patient
giving
gets.
in those splints, because if we don't give them,
Yes, yes,
we are in for some trouble.
yes, yes, sir. Soft splint was given in this case as well. Ideally, for all full mouth rehabs, we have to give it. It's best.
Yes.
Uh,
Duration probably around 6 months
Yes,
in the
sir.
night.
Yes, yes. As long as we see that the occlusal splints, when she's wearing again, there is no much amount of wear and tear of the occlusal splint that is seen after that amount of period. If you see that the wear and tear is still continuing, then definitely for a little longer period.
Hmm.
Dr.
Uh,
Danish, I have a question. Like in few cases where there is a missing canine and we have to restore it, and onto the opposing arch or the other side of the arch, we have a canine guided occlusion. Are we going to give the same kind of occlusion for the missing tooth?
Uh, Ideally, when the canine is missing, the best number of kind of treatment that has to be given is a implant for that particular teeth rather than go ahead with an FPD, because again it will involve multiple amount of teeth. You'll have to prepare all of that. So if you're giving a individual canine on that particular area, I would suggest, like according to me and this, we would suggest to have groove function on that side and let the patient continue with the canine guide that is present on the other side. So it would be best to share the load of that particular implant and not try to completely load it in eccentric movements.
Even in cases like if we are doing a post and core for a canine where we
Yes,
have to
yes,
give
yes, yes. Groove function would be better because after post and core, ideally the tooth is already a bit weaker. So we would not want to completely load it again and cross the teeth with that.
but if the patient, as you told, like in one of the slides, like if they have a canine guided, there is a
Yeah,
disocclusion of their posterior teeth. And
correct.
since the canine is missing, so how do you like it would not be in group function for all the posterior teeth respectively.
It is the premolars and the molars that will come into contact. So I think we can
Yeah,
restore it back to that. So it should be okay.
back to that.
Yeah.
Okay. So what kind of occlusion would you prefer? Like if you have to do a single implant restoration?
Again, it
In
depends on which area we are placing. Like if it is the posterior, then obviously if it's a molar that we are replacing or things like that, if it was already existing with the groove function, go ahead with the groove function. But you should have very light contacts, even if the patient is biting hard in those cases. But if there is a just a minimal, like if the patient is just biting minimally in centric occlusion, you can just have a feather touch contact or no contact also. Or in cases of very hard biting, that is where you need to have a light contact. But that again should be along the long axis and try to avoid any amount of lateral contacts that is there.
okay. Any more questions from the participants? I think there are no more queries from our participants, and I think Dr. Danish has covered almost all the things required as we understand our canine guided and group function occlusion. On behalf of GDP, I would like to thank our speaker for the day, Dr. Danish, for the wonderful
so much.
presentation you have done and clearing out all our queries related to how can we restore the occlusion in our patients. Thank you, Dr. Danish, and I would like to thank even our participants for joining and making this webinar a success. Thank you.
Thank you.